Two.
Sweet. All right, let's do it. Okay, guys, let's get back to it. This is part three of three, hopefully. As far as I've kept extending out this fibroblastic tumor session, because there's way too many fibroblastic tumors, obviously. So, but we've got one more session here to go, and then we should end it. So we'll start off kind of where we left off last time. So I think we had finished with myxofibrosarc, and let's move on to the next one. So we'll go ahead and open this up. Perfect. Okay, let's take a look here. Okay, so anyone want to start with the looking at the borders of the lesion first?
Yeah, the border, it looks like an infiltrative lesion.
It does, right? So there is
Yeah.
kind of like some areas where it's maybe more well-defined, but other areas certainly seems to extend out into the soft tissues, to the surrounding fat. All right, let's take a look at what we have histologically a little bit higher up, architecture.
Like short fascicles of spindle cells.
Yeah, kind of fascicles, spindle cells, relatively short fascicles. Let me find an area once here we go. We load in a little bit. Okay. What else do you notice?
Has this collagenous background.
It does, yeah. There's kind of a collagenous background in some areas. That's true. That's true. Okay. What else?
And others are more like almost like myxoid, and there's
Yeah,
maybe this.
exactly. Right. And I think you probably noticed it honestly even better at low power, right? So out here, sort of more myxoid areas too. So it's kind of this mixed tumor where we have myxoid and collagenous features. Okay, cool. What else do you notice?
A lot of blood vessels.
Yeah, there's a lot of blood vessels. They kind of have this interesting look to them. Okay. All right. And then cytology,
Looks bland.
pretty
Spindle
bland.
cells. Yeah.
Right, I agree. So it's fairly bland, but cellularity is quite high, right? It's a pretty hypercellular lesion. Okay. All right. So, any thoughts? Here's another one of these vessels, kind of these little curving vessels.
Um, I mean, with a myxoid background and a lot of blood vessels, I can think of like something like angiomyxoma, but then this lesion is kind of infiltrated. Um,
Angiomyxoma. All right. So, angiomyxomas, um, let's you can be a bit more specific there, right? Because there's a couple different, there's like a superficial angiomyxoma and there's aggressive angiomyxoma. Certainly could consider something like that. What's the reason it's probably not that?
Usually a superficial lesion that is multinodular. It's not infiltrated like into the fat like this lesion.
Right. Yeah. Usually it's also a bit less cellular than these generally. So, and those tumors are pretty distinctly gynae in nature. Um, so it's not actually something I'm going over. But good thought.
Yeah,
What
for
else?
this one, the other thought that I had was a low-grade fibromyxoid sarcoma.
Low-grade fibromyxoid sarcoma. Okay. All right. So, how are you making that diagnosis?
Um, on histology, we have like these myxoid areas intermixed with these more fibrotic collagenized areas.
Thanks.
Cellularity is, as Ahmed described, is more um, like bland, like this one. We have like some curvilinear vessels around back and forth.
Yeah.
Uh, so I think overall I would maybe do a MIFS for differential
Okay.
and molecular
All
differential.
right, so I think you're getting at the right idea, right? So it has admixed collagenous and myxoid features, right? So that's one of the big features for low-grade fibromyxoid sarcoma. Very bland is classically very bland, and they tend to be pretty hypercellular. Um, and when you talked about the vessels, right? So they do have a pretty classic vessel appearance, right? Where they will have more of a not exactly curvilinear, but they'll have these like curving arcades of vessels that you may see, right? That's a little bit stronger, I think, over here. Oops, sorry, it was over here. in this area. We started seeing these sort of like arcades of vessels, but that's fairly typical appearance for low-grade fibromyxoid. One thing to note is in this area that's more myxoid, it's quite cellular. It's unusual that there's a particularly unusual tumor in that the myxoid areas are generally more cellular than the collagenous areas. That's also a good indicator, which is typically kind of the opposite, right? We think about myxoid, we think about hypocellular lesions, right? Okay, so that's one thing, right? So we can consider low-grade fibromyxoid, right? And you want to do a MUC4 stain, right? Okay, so why MUC4? What exactly is MUC4 all about? What is MUC4 stain?
I think 99% of the cases are positive for MUC4. It
Yeah,
stains the spindle cells.
right, exactly. The vast majority, so the more than like, yeah, 99% of low-grade fibromyxoids will be MUC4 positive. For whatever reason, it's actually a very strong, it's a very specific and sensitive marker in this context, right? But what else is MUC4 positive in?
GI stuff.
Yeah, GI stuff, right? It's MUC4. It's an epithelial mucin, right? So this is one of those weird tumors, right, that is associated with an epithelial type mucin. So there are a couple of others, right? But there's one other epithelial mucin that is often expressed in low-grade fibromyxoid sarcoma as well. What is that? Do you guys know?
EMA?
Right, EMA. What's EMA? Come back to your
Epithelial membrane antigen.
It is epithelial membrane antigen, but it's also, remember, it's also MUC1, right? So that's another way to remember that, right? So don't forget EMA, the reason, it's one of these epithelial mucins, it's actually MUC1. So MUC4 is generally diffusely positive in low-grade fibromyxoid, but MUC1 is also commonly positive at times as well. Let's see, I think I have another example of one here, and you can kind of see this dichotomy also quite nicely from the separation from the collagenous areas and the more myxoid areas, which are quite cellular, but very bland and primitive looking cells. Now, there's one feature that may sometimes be seen in low-grade fibromyxoid. Here you can kind of see that nice dichotomy between myxoid areas and collagenous. There's one feature that we talk about kind of pathognomically, sort of the presence of hyalinizing collagen rosettes. Those, to be honest, are extremely rare. And you basically never see them, to be honest. So I would kind of not worry too much about them. I think out of all the low-grade fibromyxoids, I've maybe had it's probably like 1 in 50. I feel like I've had one that has hyalinizing collagen rosettes. They're not very common, to be honest. So it's really just not that great a marker. All right, so yep, you guys are correct. This is low-grade fibromyxoid. These are both examples of low-grade fibromyxoid sarcomas. So let's talk about them. Okay, low-grade fibromyxoid sarc. So we'll talk about the histologic criteria first, just because we're kind of on that train of thought, right? So you generally are supposed to have this sort of alternating myxoid to collagenous background. Sometimes they're separate, where you have like clear myxoid areas and clear collagenous areas. Sometimes they're actually kind of admixed together. As that second example kind of showed, they were kind of like a lot of collagen mixed in. So they can be kind of admixed in various proportions, and usually have these sort of thin-walled arcades of vessels, right? I think about arcades, we're talking about sort of like, Roman columns, basically Roman arcades, right? Those little arches. And additional features, like I mentioned, often the myxoid areas are more cellular. You might have some hyalinizing rosettes in a very small subset. And then some of them have an association with a different tumor, which we'll talk about in a minute. Like we said, almost all of them are MUC4 positive, and EMA is actually positive in a significant number. And then there's a fusion, right? So think about these tumors. They are Krebs family rearranged. So this is one of the many tumors in the Krebs family, right? The sort of a widening spectrum of tumors that have Krebs rearrangement. Nowadays, Krebs family rearrangements are seen in a whole host of fibroblastic, non-fibroblastic, and epithelial tumors, round cell tumors, even a subset of mesotheliomas, for example, will have Krebs family rearrangement. So the melanomas, that kind of thing. So it's not as specific these days. So you have to remember, really make sure that you understand the histology as well. Because just finding the Krebs fusion is not exactly a 100% clincher, right? Okay. So, but let's talk about the clinical. The reason there's a sort of a weird tumor, right? So low-grade fibromyxoid is kind of a misnomer almost. It sort of looks low-grade, right? Morphologically, it looks low-grade. It's actually kind of a bad tumor, right? So this is something to really keep in mind. You're running along, thinking about this tumor. You should always really just kind of consider doing a MUC4 if you have kind of like a bland thing with myxoid features, just to make sure you're not missing this, right? Because it is a malignant tumor. It has a pretty wide age range. They're usually kind of younger adults, most often in the proximal extremities, but it can happen anywhere. And that low grade idea is based off the morphologic appearance, right? But it actually has a really high risk of local recurrence. These things are quite infiltrative, and the natural history is for it to recur quite often. So recurrence up to like 65%. And the problem with these is that they have this weird propensity for late stage Mets. So it's actually the Met rate is pretty small, like 5-ish% in the first 5 years. But past that, Met rate is actually pretty high, up to like 45%. And the problem, these Mets can be like 15, 20 years later. Sometimes they're like 40 years later. It's a real problem, right? So this is something that you don't want to miss necessarily. So that patient is kind of being followed to make sure that this thing is not coming back or is metastasizing. So that's a big problem with this. Okay. So any questions about low-grade fibromyxoid?
I have a question. How do they treat it once it's met?
Once it's met, so again, it generally will be treated, usually it's going to be treated with like local surgery, right? So the local therapies. If it's like widely metastatic, they might consider some chemos. Again, it is a low-grade tumor. It's not super like proliferative generally when it's like this. So it's not exactly going to be super chemo or radio sensitive, right? You can try radiation, but it's possible. But there's not a whole lot of options, right? So usually they'll resect or they'll kind of come back to it, right? But yeah, so mortality can be pretty significant over time for these things. Cool. All right, let's move on to the next one. Here we are. Okay. Yep. All right, so here's the next one. I won't tell you where this is because the location is kind of weird. So I'm not gonna like confuse you guys with it. But what do you guys see for this tumor? What about once this kind of settles in? What about architecturally? Kind of what are we looking at here?
Like short fascicles, maybe soil form.
Right, there may be some fascicles around here, but the significant component of this is maybe not even like all that spindled, right?
Yeah.
Right, you can see there's kind of like relatively, bland looking cells, to be honest, but how would you describe them?
They're round. They have this like clear cytoplasm, but they also seem like they're matrix producing with this eosinophilic kind of sclerotic area around them.
Yeah, exactly. So they're kind of round, maybe epithelioid, kind of there has this sort of clearing to them, but they are producing a fair amount of like intervening sclerosis, right? So that's pretty typical. Okay. But yeah, quite bland. There may be some areas of, I don't remember if there's any necrosis in here or anything like that, but overall, relatively bland looking tumor. This is probably not the best spot here. We'll just show this area. So relatively bland looking tumor, maybe a few mites, but not a huge amount. It's kind of deceptive looking, right? So, but presumably, I think you guys are probably seeing where this is going if we kind of put together some of those words that we've already mentioned, right? So maybe sclerotic background, maybe some epithelioid features, right? Okay, so anyone want to shout it out?
Sclerosing epithelioid fibrosarc.
Yeah, this is sclerosing epithelioid fibrosarcoma. So this is one of those situations that is, let me see, do I have a second one? I do, yeah. So this is one of those situations where we're dealing with kind of like a tumor of somewhat related to the previous tumor that we were talking about. And the way they're related is through their molecular features. They're going to be the same molecular kind of fusion. They're both MUC4 positive, and this is our MUC4 stain. Nicely MUC4 positive here. And then and they're actually been associated with each other. So there have been cases that have been described that are sort of hybrids between the two of these. So I'll go ahead and show you the slide here. So this is sclerosing epithelioid fibrosarcoma. So both of these tumors can have kind of components of the other one. So they can be kind of this mixed low-grade fibromyxoid sarc with sclerosing epithelioid fibrosarc, or they can be de novo, right? And SEF is one of those rare tumors that you really only see once in a blue moon, I would say. It's kind of rare, but they can be they're generally more aggressive, right? So they are more quickly aggressive early on Mets than low-grade fibromyxoid. So if you have any sort of component of SEF, you should really consider that this is going to be treated more aggressively. The recurrence rate is pretty high, and Mets kind of early on are pretty high as well, right? So 40 to 50%. Even hybrid tumors that are like, for example, predominantly low-grade fibromyxoid, if there's an SEF component to it, they tend to behave like SEF, right? Which makes sense. Most often these are kind of deep-seated tumors, but what you're looking for histologically, epithelioid cells of either nests or cords within a dense intracellular sclerosis or hyalinization. That's your histologic criteria. You may also see that they're quite bland often, monomorphic. They're kind of deceptively bland. But they can have some atypia, but most of the time they tend to be somewhat bland. They can have clear cytoplasm, and they can have that LG-FMS, low-grade fibromyxoid component. Like we said, MUC4 is generally positive, EMA may be positive, and they're CREB rearranged, usually with EWSR1. That's the most common. Okay. Any questions about SEF? All right. So those two tumors kind of have a lot to go. They kind of go hand in hand, right? So think about them together, right? But they're very kind of interesting tumors. All right. Let me see. So next up, I think I have another slide. Let's take a look. All right. Oh, that's right. First of all, give me 1 second. This one I actually wanted to show on glass. Let me pull open my cell sense real quick. All right. Okay, so let's go ahead and open up cell sense here. So this one I was going to show this first example on glass.
Oh.
All right, and I'll show you first that we have essentially skin overlying here. And then we have what looks to be a subcutaneous mass, right?
Mhm.
So now let's take a look a little bit higher up and see what we see. So what do you guys want to say about this? So let's look at the borders first, I guess.
Encapsulated, I think.
Maybe encapsulated, at least partially encapsulated, but
Yeah.
maybe a little bit ill-defined on the edges over here. Okay. Let's look at architecture or stroma.
From low power, I thought it was kind of corded, but I don't.
There's something that's kind of cording through, if you can tell what that is.
It's like blood vessels or
Yeah, they're probably blood vessels. So we're seeing these interesting kind of blood vessel formations. Okay.
We have this myxoid background.
Yeah, very myxoid in the background. That's true. What else do you notice in the background?
A lot of inflammatory cells.
Yeah, plenty of inflam, right? So kind of mixed inflammation.
Mm.
Let me see if we can find another area here. Here's another area. See, there's plenty of inflammation.
Mm.
It's kind of a mixed kind of fibrous to myxoid features.
Yeah.
All right.
Some larger cells.
Yeah, there are some bigger cells that are kind of sitting in here. That's true. Let's see.
Wait, stop. That cell.
Yeah, that one looked like a prominent nucleoli.
Yeah, there's some prominent nucleoli. That's true.
Mm.
There may
Like
be
a
some big,
virus.
like a
Mm.
virus-like cell, huh?
Mm.
Could be. What are you trying to get at here?
Yes.
MIFS.
Myxoinflammatory fibroblastic sarcoma. Mm.
There you go. These
Ooh.
guys here.
Oh, that's a good one.
Yeah. So big virus-like cells are sort of sometimes called like Reed-Sternberg-like cells.
Mm.
You're kind of wondering about myxoinflammatory fibroblastic sarcoma, right? So the long name for whatever it is, right? And that's true. That's what this is. So this is a MIFS or myxoinflammatory fibroblastic sarcoma. And even though there's quite a lot of atypia here, mitotic activity is really low. There's not all that much, right? So we're just kind of seeing mostly these big virus-like cells.
Yeah.
So that's one example of a MIFS.
Oh, that's nice.
Let me see. I think I have another example on glass
Let's
here of
see.
another MIFS here. Sometimes they're not quite so like fantastic as that, but a lot of inflammation,
Mm.
mixed and mixed fibrous and myxoid background, kind of like
Mm.
these myxoid areas, right?
Yeah.
And within these myxoid areas, you can see our cells of interest generally. Let me see if I can, let me pull out another area here. Oop.
This one has less of a myxoid. Oh, never
Right,
mind.
exactly. It has these like little pockets with these big cells there, kind of virus-like cells, but less kind of predominantly myxoid. There's maybe a virus-like cell there, right? So they're kind of scattered about. This thing also has an area that I wanted to highlight as well because where is it? Here we go. It has kind of a background of mixed adipose tissue and some like fibroblastic tissue here.
Yeah.
Kind of these bland spindle cells in the background, and a little bit of pigment as well. This kind of brown stuff here, right? So this one has a background of a kind of a somewhat related tumor called hemosiderotic fibrolipomatous tumor. We're not actually going to talk about that today, but it is one of these things that these can occasionally be seen with one of two other neoplasms that are somewhat related, but the relationship is kind of dubious, we'll be honest. But anyways, yeah, here you go. Some of these. So this is an example of a MIFS, just kind of a different one.
Is this like more on the spectrum of what you see in regular practice, this kind of look versus the first one, which was more textbooky?
Oh yeah, I think you'll see both. To be honest, you'll
Oh,
see
okay, okay.
see both. Here's another one that we had. Just kind of another example of one where again you see these kind of like myxoid regions
Mm-hmm.
and very kind of prominent virussite-like cells, very kind of prominent epithelioid to pleomorphic cells, but again very like low proliferative activity.
Mm.
So this is kind of a fairly common look, I would say. Um, here's a, probably if I can find another example around here. Sometimes there are fewer and far between. But anyways,
Some
another
of these
example.
cells look like they had like mucin vacuoles in their cytoplasm. Is that true, or am I just
Yeah,
picking?
so there are within MIFS and mixed fibrosarcomas, you'll occasionally see like pseudolipoblasts.
Yeah, yeah. Oh, okay.
It's because they're filled with mucin, right?
Right.
So that's what like these cells are. It's like a pseudolipoblast.
Sure.
So that's fairly common. All right, so that's an example of the MIFS. Let's
Nice.
pull this down.
So
Oops.
this one is not a myxofibrosarcoma.
Nope.
He said nope.
Myxoinflammatory fibroblastic sarcoma. Long name for whatever it is. These are technically malignant, right? But they are more local recurrent. Um, Mets are actually extremely rare, usually less than 1%. The vast majority of these are in the distal extremities, so you're pretty much always going to see them kind of in the hands and feet or kind of around the distal extremities. Sometimes they can be more proximal. Um, and most often in the hands, right? It's a pretty wide age range as well. And like I said before, there may be an association with some of these other tumors, called like hemosiderotic fibrolipomatous tumor or HFLT or PHAT, which is pleomorphic hyalinizing angioectatic tumor. I wouldn't worry about those yet. We'll talk about those eventually, but I'll say that the 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 connection is kind of dubious, and kind of unclear, right? But it is well documented that you can get hybrid tumors between these three entities. Okay, so your histologic criteria for these things, generally they're going to be infiltrative to multinodular looking, and they'll be myxoid to kind of a hyaline matrix, but there'll at least be some focal myxoid change. Usually there's a Myxoinflammatory infiltrate and these atypical spindle cells with the virus site-like nucleoli. That's kind of what you're looking for, right? And also, mitotic activity is going to be generally very low. If you start having more than that, you start having a lot of mitotic activity, you get out of the realm of MIFS generally, and it's more, it's possible that you have what's called high-grade transformation of myxoinflammatory fibroblastic sarcoma. Or, those tumors are going to behave more like a high-grade sarcoma, right? They'll behave more along the lines of a metastatic tumor, right? So you don't really want to call it if you have a lot of mitotic activity. Yeah. So like I said, they can have pseudolipoblasts. The cellularity is pretty variable overall. They can actually show in peripolesis. And then, like I said, they can have hybrid features. So IHC is generally not useful. Neither is molecular. Some of these will show some weird translocations around like the MGA5 gene. That gene is not really expressed necessarily. There's not like overexpression. So it's not really, we're kind of picking it up. It's not clear that it actually is functional in any way. Some cases show BRAF fusions as well, but there's really not like super helpful molecular testing for this. It's really a morphology diagnosis. Okay. That's MIFS. Any questions about MIFS? It's a weird case, right?
Yeah, I have a question.
Yeah.
For the hybrid, like if you see them with the hemosiderotic fibrolipomatous tumor or the PHAT, shouldn't those have like the hemosiderin-laden macrophages or not necessarily?
They often will, right? So if you'll see a background of hemosiderin in both of those tumors. So very commonly you'll see that if they're admixed, you'll see a hemosiderotic area. And PHAT will also have hemosiderin very commonly as well. So those, if you have those hybrid tumors, you'll often see both components there. But either way, it doesn't change too much, right? The bigger importance is the MIFS, right? So if you see the myxoinflammatory, because the other two are both completely benign, right? Yeah, so that's kind of one thing to note.
But would MIFS on its own ever have like
You
any hemosiderin anywhere?
know,
Possibly. Or not really?
if there's like some bleeding in the tumor, I suppose it could, right? But the other thing to consider, right, is that hemosiderin, um, in PHAT, it's going to have other features, right? So it's going to have like these hyalinized ectatic vessels and very pleomorphic stromal cells, right, with hemosiderin. So you'll want to still look for features there, right? So just because you have some hemosiderin doesn't mean you're dealing only with the MIFS or with you're dealing with something else. It could be a MIFS though.
I have a question.
Yeah.
So if you have a MIFS, but then you have the higher mitotic activity, do you even call it MIFS or do you just go to high-grade sarcoma?
Yeah, I will start with high-grade sarcoma generally.
Okay, sure.
And I might comment if I'm feeling particularly like full of myself. I'll comment and say like it may be a transformation from
Sure.
inflammatory. If I'm like feeling like I need to impress the patient anyway.
Sure, okay. Fair enough.
I get that. I get that. I've done that before. But yeah, most of the time you want to go with kind of the more important thing.
Yeah, sounds good.
And you also want to consider, is it like, do you say high-grade sarcoma or does it have better features for like a mix of fibrosarcoma that just
Oh, okay.
has some inflammation? So you want to make that distinction too, right? Because high-grade sort of undifferentiated sarcoma, a transformation, those behave a little differently. They have more metastatic rate than a mix of fibrosarcoma, which we talked about last time. Tends to have kind of a mildly less metastatic rate,
Yeah,
right? So, you want to be a little bit like judicious about how you give that.
sure. Thanks.
Cool. All right, sweet. Let's move on to the next one. I think we might be the next few I think may have we may be just looking at kind of like pictures and stuff. But let's see. Oh, this is kind of showing these a
Ooh.
little bit higher up these virus-like cells, by the way, just so you can see it. Okay. Did I have? I guess I had an additional. Let me see.
These fibrosite cells, they don't stain with nothing.
Yeah, they don't stain. Yeah, I mean, like they stain variably with like 34 or SMA, but they're not very specific.
Okay, okay.
This was another MIFS. I think this was, I put this on here because this was an example of one that had high grade transformation. So it has kind of like this myxoid background that's very inflamed, and a couple of these areas that look like virus-like nucleoli, but it ended up having, oops, quite a lot of mitotic activity. So this is one of those where maybe it began its life, there's like an atypical mite there.
Yeah.
Maybe it began its life as a MIFS, but then it transformed, right? So,
Left.
so this is kind of what that might look like. Okay.
Okay.
All right. Okay. Before you doubt, I think Cleveland Clinic also said that. So I'm not the only one that put it in my comment. All right. Okay, we have another digital slide. I kind of forgot what we're looking at here. Let's see.
21.
All right, next up. Oh yeah, this one. Okay, so we're moving on. Let's take a look at this one next. What do you guys think about this one? We'll start over here. Once it loads in here.
Smaller
All right.
cells.
What do you guys think? Sort of architecturally, what are we looking at here?
These short
I think this is
fascicles. I feel like I'm
similar.
seeing cross sections of short fascicles.
Yeah, kind of getting like some short fascicles. Okay, fair enough.
Bezels kind of look compressed.
Yeah.
Mm-hmm.
And maybe thick walled. I'm not sure.
The little guys here, some vessels, right? That's true. Let's take a look at another
Bland.
piece. It's fairly bland. It is at margin, whatever it is. I kind of excise this a little closely. Give it a second. Very bland, but quite cellular, right?
Yeah.
If you were to see this in other contexts, I mean, could be a number of different
Leiomyoma.
cell. Certainly leiomyoma, it could be a number of different spindle cell lesions.
Yeah.
But then what about, well, I don't know why it suddenly is going slow. Give me a second. What about's going on over here?
Oh, is this cartilage?
Like a chondroid. Yeah, matrix.
Yeah, almost chondroid, almost kind of looking, could it be chondroid? There's a few giant cells kind of around the edge. That's true. Okay. What else are you seeing? What is this stuff?
Maybe calcium.
Yeah.
There's calcifications as well, right? So this kind of background, bland, spindled, hypercellular lesion with kind of this calcifying matrix in the center, right? That happens. Okay. Here on the edge of that, you kind of get these more, somewhat like epithelioid palisading cells around this,
Oh.
okay, and then giant cells as well. What do you guys think this could be? I'll tell you it's on the hand, I guess, maybe. It's somewhere on the hand of like a, I don't know, like a 15-year-old or 20-year-old.
Could these not be calcifications like phosphaturic mesenchymal tumor? But I don't think it would look
All
exactly
right,
like this.
so phosphaturic. Okay, so now we're getting into the differential for this thing, right? So phosphaturic mesenchymal tumor, rare, weird, fun, interesting, great thought, but thankfully it's not. But we'll talk about that for sure. But you're normally looking at sort of like a grungy kind of calcified background in PMT, which these can sometimes mimic, right? Because it almost looks a little grungy looking, right? Okay, what else? Anything else?
I don't know. I'm thinking of B-pop, but it doesn't have the blue bone.
Right. BPOP is more of a bone forming lesion, right? So you think about bone, right? Or for people who are wondering what BPOP is, it's bizarre parosteal osteochondromatous proliferation. But that is more of a fibroosseous type lesion, right? So you get bone formation and stuff. And we're not really forming any bone necessarily.
Tumoral carcinosis, maybe.
Tumoral calcinosis, okay, that's a thought, right? Because you get these sort of multinucleated giant cells surrounding areas of calcifications, right? So tumoral calcinosis, possible, but then you get this spindled stroma in tumoral calcinosis. No, not really, right? Anything else? Anything else?
Chondroblastoma.
Chondroblastoma, if it was in the bone, you might wonder about
Oh
that.
yeah, right.
Could you be wondering about, could these be like intervening, sort of chicken wire calcifications that you might be wondering about and stuff like that? Okay. But we're in the soft tissue. I mean, we're in the fibroblastic range of tumors still, so you know. Um, but okay. Any other thoughts before I can give it to you? So this is a weird tumor, right? It's not something we talk about a lot, right? I haven't really sat down with you guys at lecture all that often to talk about it. But this is what's called the calcifying aponeurotic fibroma. I think it looks like Lacey kind of had it.
I don't know, she's just celebrating. We didn't hear any words.
I didn't say it, but yeah.
And she thought it in her mind, it was in her mind. So it's a calcifying aponeurotic fibroma. So these things are generally they're benign lesions, though they're very commonly recur. Like I said, they're usually distal extremities, right? Usually on the palmar or plantar surfaces, and often in adolescents, but it can occur in adults. So they're more likely to see it on the kid side, which is why we don't see a whole lot of these over here. But the histologic criteria, generally, they're pretty infiltrative. They have this kind of fibromatosis-like stroma. So the cytology, the cellularity often looks a bit more like fibromatosis. They're pretty bland, uniform, plump spindle cells, and they have this collagenous to chondroid matrix that forms. And that matrix kind of has these sort of geographic areas where they start to calcify, and they're surrounded by these palisaded cells, right? And multinucleated sort of osteoclast-like giant cells are very common. It's a sort of a necessary feature, but common. And then sometimes because it's fibromatosis-like, it can invade and you can get this sort of admixed adipose tissue, right? IHC is not exactly very helpful, right? They can be kind of SMA positive for whatever reason. And if it's a chondroid area in there that's like true cartilage, you can get S100 positivity, but that's not particularly useful. The big thing is that as morphology is better diagnosis, right? But the big thing is that this kind of often has these sort of FN1 gene rearrangements, right? All right, so let's talk about the differential for this because Muhammad brought this up in terms of differentials. So we talked about PMT as one, right, which has this sort of grungy calx, usually more staghorn vessels, right, but they can have this sort of grungy calcified background. What do you need generally? What is a very common feature in PMT, phosphaturic mesenchymal tumor, that is very useful to have?
Beside the
Malaysia,
What's that?
FGR,
Yeah, exactly. So
FGFR23, something like that.
right. So you'll want serum studies for osteomalacia. You'll be looking for osteomalacia or osteogenic osteopenia. So you'll be looking for serum studies for that. And then also you want generally they're rearranged with FGF23, right? Or you can do with like FGF receptor 1, I think. And you can actually do serum testing for that too. So those are both options. What else? Anything else that could be in this differential?
Epithelioid sarcoma.
Epithelioid sarcoma, okay, right? If you're wondering about could those kind of palisaded epithelioid cells be surrounding like more necrosis, more like granulomatous-like look, you could wonder about epithelioid sarcoma. It's a possibility. Other big things to think about are pseudogout.
Fibromatosis, maybe.
What's that? Sorry, go ahead, Alcino.
Fibromatosis,
Fibromatosis,
like
certainly could be,
superficial fibromatosis.
right? Could just consider like palmar fibromatosis, right? Yeah.
Fibroma of tendon sheath.
Fibromas of tendon sheath, okay. Could be considered, but you're missing some of that. You won't really have those calcifications in there, right? So other things you might consider, things like pseudogout, it's like tophaceous pseudogout will have you'll see those like they'll look like calcifications. They're actually crystal deposition, right? So think about that. Synovial chondromatosis, if this is around the joint, you might wonder about that. Tenosynovial giant cell tumors as well. Some subset of them will have cartilaginous metaplasia. And in fact, there's thought that some of these two lesions are probably the same thing, right? Some tenosynovial giant cell tumors with cartilaginous features have FN1 gene rearrangement. So there may be some overlap in there. There's also a new tumor that we've kind of dubbed calcified chondroid mesenchymal neoplasm. So that's also in this overlapping spectrum. They also will have FN1 rearrangements, right? So we're kind of like, where do they fall on this spectrum? But anyways, so there's a number of things. As long as it's not a PMT, I think you're okay. Cool. All right. Sounds good. Any questions about this case? It's calcifying aponeurotic fibromas. They're weird little guys.
Weird little guys.
All right. The rest of them, I think, if I remember correctly, are mostly pictures. So let's talk about them. First off is these are things that we don't really get a whole lot of. I'm sorry. I probably have seen I guess I've seen all of them at one point in my life, or most of them. But I don't have slides for all of them, unfortunately. So these are a long time ago. The first one we're going to talk about is what's called superficial CV34 positive fibroblastic tumor, which is kind of what's written on the tin, honestly. We have a weird naming thing. When we can't think of a name, we just kind of say all the words out together, So, but generally, they are pretty indolent tumors, right? And they can get local recurrence. Mets have been described extremely rarely. Generally, they're more benign. They have pretty excellent prognosis overall. As true to its name, they're usually superficial, most often in the extremities, right? Usually in adults, right? The histologic criteria here, we'll look at some pictures, but I want you to pay attention to the cells themselves. They are pleomorphic, right? Generally, there's marked nuclear pleomorphism. It's one of these tumors that has a lot of pleomorphism, but actually behaves quite indolently. And then they will often have this sort of eosinophilic to glassy cytoplasm. Should be basically no mets, right? Or no mites, right? Very low mitotic activity. They can have inflammation, they can have infiltrated borders, but those are less important. The big thing here is that it's 34 positive, the vast majority of them, so CD34 positive. And then pankeratin is actually positive in a large subset of these, so that's very common. It's usually with A1, A3. And then something to consider is that PRDM10 rearrangements are sometimes seen in these. It's actually thought, we used to think PRDM10 rearrangements, we used to say they happen in a subset of undifferentiated pleomorphic sarcomas. And then we saw that those PRDM10 rearrangements actually did better. And it's probably that they exist more in this spectrum overall, right? So, but anyway, so this is what they look like. So you can see kind of pleomorphic tumor, kind of glassy eosinophilic cytoplasm, but no mitotic figures, right? And they're generally diffusely 34 positive, and this one was also A183 positive. So it's just one of these weird kind of superficial tumors that kind of plays a strange role. Something to think about whenever you have a weird pleomorphic tumor in kind of the skin or subcute.
So glassy cytoplasm. How is this different from like a smooth muscle differentiation, the cytoplasm?
Well, it won't. So it won't have that kind of nice pink. Kind of smooth muscle is going to be much more like homogeneous pink, right? So it's
Okay.
kind of bright pink cytoplasm of like, think about a smooth muscle wall of a
Yeah.
vessel or with a myometrium, for example. This doesn't quite have that look, right? It still has this kind of more collagenous background, right?
Okay.
Or like you see a more like fibrillary kind of deal.
Okay.
That's why it's kind of more thought to be more fibroblastic.
Okay.
Okay, cool. Sweet. All right, let's move on. So that's super, it's not something you run into very often, to be honest. I think I've seen 2 in my life.
Okay.
Here's another one that's pretty rare, I would say. And to be honest, it's a little bit like difficult to even make this diagnosis anymore. But it's called low-grade myofibroblastic sarcoma. It's basically just an extremely rare low-grade malignancy. Local recurrences are pretty common, but mets are rare. But some will show progression to kind of like a higher grade myofibroblastic sarcoma. It's the same idea as like adult fibrosarcoma, in that we think that, okay, if it looks myofibroblastic and it looks enough of a sarcoma, then we can call it a low-grade myofibroblastic sarcoma, right? But the histologic criteria are pretty vague, I would say. It generally needs to be infiltrative. There needs to be at least some moderate to marked cytologic atypia, at least, right? You have to have something. And then it has to stain in some way for myofibroblastic markers, okay? It's kind of a tough call to make overall, because you might look at this and wonder, can you really call this a sarcoma necessarily? But this one has kind of like a little bit more moderate cytologic atypia. It's pretty infiltrative on the edges, and it has a fair bit of mitotic activity. Here's one that has more kind of like fascicular features, and they're kind of scattered pleomorphism, right? So these at some point have been called low-grade myofibroblastic sarcoma. To be quite honest, it's not exactly a tumor that I call at all, really. So it's just one of those weird kind of tumors, right? So it's
What
not
look
something that you're going to run into, I think.
do you see this look in other lesions that we have names for?
Not really, to be honest. I mean, the
Okay.
thing is like it's myofibroblastic in nature, right? But the
Okay.
question is, does it really deserve to be called a sarcoma or not, right?
I see what you're
So a
saying.
number of myofibroblastic tumors, because you can see it has that nice amphiphilic stellate
Mm-hmm.
cytoplasm, right? Of a myofibroblast. So you can tell it's kind of myofibroblastic looking. But um, for example, some variants of nodular fasciitis could
Yeah.
be a little bit infiltrated. Could this be a proliferative fasciitis? Could this be something in that
Yeah.
spectrum? There are certain types of those tumors that are much more cellular and have a lot of mitotic activity, right? So it's really we're left up to like there being kind of some significant atypia, at least focally, for it to really be called low-grade myofibroblastic sarcoma. So it's kind of a tough call to make, right? It overlaps a lot with the children's tumor called myofibromatosis as well. So some
Mm.
people will say like, even though, if you have like a fibromatosis like tumor that's more infiltrative, but is predominantly myofibroblasts in origin, you might call it myofibromatosis.
I
Again,
see.
these things kind of like overlap, and it's really a difficult distinction to make between these. Boards will never ask, obviously. Just in real life, I have not made this diagnosis. I mean, I think we had one when I was a resident, when I was a first year. And since then, we haven't really made this diagnosis ever.
Okay.
It's a tough call to make, honestly. I don't think most of us make it anymore. All right. Now we have a set of some kids tumors. And again, like I don't really have kids tumors all that often. But we'll show them real quick. We'll rapid fire, right? So we got fibrous hamartoma of infancy, which is kind of the most fun one, right? Because I think everybody loves to see the triphasic components, right? So it's benign, right? But it's infiltrative, right? So it can recur locally. Almost all these are in children, almost all of them in, children younger than 2 years old. They classically have a nice triphasic morphology. So they're composed of adipose tissue, this bland kind of fibroblastic background, and then nodules of primitive mesenchyme. So that's what these are. So fat, fibrous fibrous tissue, and then this sort of primitive mesenchyme here, right? These kind of like whorls of mesenchyme. There you go. Classic, easy. When you go to, peds, you'll see these. Not all the time, but you'll see a couple probably. You'll see maybe one. I don't know. Usually there's no mitotic activity, pretty much, no necrosis. There have been associated rare cases that have had sarcomatous transformation, though. So that does happen, sort of like a sarcomatous morphology. It's actually kind of unclear if they're really a sarcoma. They behave like a sarcoma in those areas, and then some of them may show what's called like giant cell fibroblastoma-like regions, which we'll talk about in a second. Stains are not very useful, but you can get variable SMA in 34. Okay, next up, rapid fire lipofibromatosis, kind of similar to the last one almost. You might think about it because you have admixed adipose tissue. It also had admixed kind of fibrous area, similar to fibromatosis, kind of like a hypercellular, bland, spindled fibroblastic appearance. But this thing doesn't have those mesenchymal kind of primitive mesenchyme. They're benign. They are very recurrent, right? So these things are very infiltrative. They recur quite a lot and usually in young patients. But they're often congenital as well. So you can see that nice example here, showing you this sort of infiltrative appearance into the muscle, kind of admixed fat, right? The histologic criteria here, like we mentioned, adipose tissue, intermixed fascicles, bland spindle cells, and then it often entraps stuff, right? So they may also have sort of like lipoblasts-like cells because they're kind of admixed spindled and adipose tissue. So don't be fooled by that. Sometimes that can be the case. They're usually 34 positive, right? There's nothing consistent molecularly. Some of them have EGFR fusions or something like that. Something to note, there's one weird tumor that is sort of similar to lipofibromatosis called like lipofibromatosis like neural tumor. Has anyone heard of that tumor before?
Is that what you had, Ahmed?
Um, I don't think so, but I think these are NTRK rearranged.
Yeah,
right?
exactly. There's one, they tend to occur in the guy around the vulva, I think. So there's this sort of like usually kind of like vulvar tumor called lipofibromatosis like neural tumor. And those have an appearance similar to this. They will generally be sort of S134 positive, which we haven't talked about, but NTRK tumors and TRK rearranged tumors are often co-positive for S134. So it's we'll talk about that in the undifferentiated tumors. Category later on. But yeah, so that's kind of something that pops up occasionally.
Are those ERPR positive?
You know, I don't think so, but I'm not
Okay.
100% sure. It's a good question. I mean, I've only seen like two of them, so and it's usually Dr. Wei who signs them out.
Right.
But yeah, but these guys, they're not gonna be. Yeah. All right, and then I think we have infantile fibrosarcoma to finish up here, or almost finish up. This, as opposed to what we talked about with adult fibrosarcoma, which is basically kind of like not real. It's kind of a figment of our imagination. Infantile fibrosarcoma is very real. And it is a malignant tumor. It's very locally aggressive, though it's not super high met rate. It's about 10 to 15%. The vast majority are within the first 2 years of life. And actually, some of them are congenital. And there's another name for these. It's called congenital fibrosarcoma. A couple of them are in or in older patients as well. Um, it's actually thought that if you've had peds and you've seen congenital mesoblastic nephromas, for example, in the kidney, there's a cellular variant that's called cellular mesoblastic nephroma that is actually seems to be related to this lesion. It might be the same thing, to be honest. So these kinds of things kind of overlap as well. But the good thing is that these things they universally have some sort of NTRK rearrangement or kind of a related gene, usually with BRAF or MET rearrangement, but most often with NTRK, ETV6, NTRK3, right? And that's very important because those patients have access to targeted therapy, right? So larotrectinib is an NTRK inhibitor, so you can use an NTRK inhibitor for these patients, which is great. There's actually quite a high survival rate with these. So even though it's a fibrosarcoma, that combination of like surgery and chemo actually does quite well for these patients. Okay. So when we're talking about histologic criteria, there's kind of a weird sort of broad histology with these. They tend to be either kind of like spindle to more primitive looking in fascicles to herringbone architecture. And they'll have this kind of variably collagenous to myxoid stroma. A lot of them will have staghorn vessels for whatever reason. Mitotic rate and all that can be pretty variable. And staining is not super useful. It can be variable with a lot of things, right? But pan-Trk stain, if you want to do a pan-Trk stain, that is positive generally, but it's not entirely specific, actually. The stain is the NGS is much more specific, right? So here's what that looks like. See these nice kind of plump, primitive looking spindle cells and herringbone pattern, right? And it kind of has this nice like fascicular herringbone pattern, similar to what we kind of thought about for adult fibrosarcoma, which is why they call this infantile fibrosarcoma. And very often it will have staghorn vessels, right? And then pan-Trk is very commonly positive, right? It's like we mentioned, S134 for any NTRK related tumor, kind of co-positive very commonly as well. All right,
How do
cool.
these present?
What's
Big
that?
masses? How do they present? Like
Oh yeah, they can present as big masses, but well, the thing is like proportionally, any mass in a baby, in a baby,
exactly as a big mass.
they all look kind of big to those babies.
Right.
Yeah, so they can be pretty aggressive tumors. At least locally, they can be pretty big. Cool. All right, let's see. And then, okay, so that was it. All right, so we've gotten through a lot. And I know it's like the last little bit here was just kind of like rounding up the last few, but I didn't want to go too long on session 2. So here's everything we talked about, almost everything we talked about. There's a couple things in here that I snuck in that are not, that I didn't want to talk about basically because they're kind of ridiculous tumors. But that's the majority of them. The reason why fibroblastic tumors are so difficult is because there's so many of these same things, there's a lot of overlap. There's a lot of different tumors that kind of fall into the same spectrum as we've talked about. Go back through, obviously, listen to various areas, but I do want you guys to make a concerted effort to really like look at these tumors when you get them and try to like justify for yourself, why am I making this diagnosis? And then also try to put it at least into like a category, right? It was like, maybe I'm not so sold that it's proliferative fasciitis, but I can at least think like, hey, it's sort of in that vein of a fasciitis-like lesion. At least
Yeah.
if you can get into that category of like, well, it looks sort of like loose myofibroblastic, a little heterogeneous background, maybe extravasated RBCs. It helps to see that and not think, oh, it's a solitary fibrous tumor. Think
Right.
like, oh, it's more this sort of fasciitis-like picture. To that end, I've kind of put in a little bit of a summary here on sort of the morphologic kind of archetypes of how these things fall into. And this isn't like meant to be completely comprehensive, but it's to help you kind of think about things in kind of groupings. The whole point of going in through line of differentiation like we are now is to really like narrow things down as much as possible into smaller groups. So if looking at morphology can help you narrow down into certain groups as well, that can help too. And it also helps you think about other things that are outside of the fibroblastic. So even though you might be like, well, there's some fibroblastic looking cells or there's collagen. If you think about it like in the morphology spectrum, you also remember, oh, wait, there's a couple of other tumors in the neural that may do this as well. So that's what this is for. So on the left, you can see the tumors that have sort of fasciitis like stroma in the fibroblastic tumors. And then what you might see in other types of tumors, other differentiations or other situations. So thinking like fasciitis type lesions like nod-fasc or myositis ossificans or ischemic fasciitis, these kinds of things. Often sort of USB6 rearranged type tumors. But you can also see similar features in infections, like if you have granulomatous infection, synovitis-like cases can be sort of fasciitis-like, foreign body reactions, giant cell granulomas, aneurysmal bone cysts in the bone certainly can have like a nodular fasciitis like stroma, but you can also get those in the soft tissue and sort of solid type as well. So there can be some overlaps there. So that's kind of helpful to think about those types of lesions. Another thing we tend to think about is like monomorphic spindle cell tumors. So kind of more bland monomorphic spindle cell tumors overall. There's quite a number of fibroblastic tumors that fall into that, along with things like fibromatosis. There's also, as well as like RB loss spindle cell tumors that we talked about, cellular angiofibroma, myofibroblastoma. These things are often kind of monomorphic. But when you think about monomorphic spindle cell tumors, you're often thinking about translocation-driven tumors very commonly. So things like DFSP, things like SFT, infantile fibrosarc, low-grade fibromyxoid sarcomas, these other fibroblastic tumors, which we're not talking about, even though Ahmed's very familiar with one of them. So there's a number of random tumors, right? So think about translocation tumors in these realms, but also translocation tumors in other realms, like synovial sarcoma, clear cell sarcoma. These are commonly very monomorphic. Entrec rearranged spindle cell sarcomas. But then there's some other tumors that may fall into this as well, like myopericytomas can often be quite monomorphic in the pericytic phenotype. Kaposi sarcoma is a vascular tumor that's spindled, has different features, but the spindle cells are quite monomorphic, right? As opposed to angiosarcoma, which generally will have some more significant atypia, right? MPNSTs, they often fit that differential with synovial sarcoma. So it's just keeping the doors open a little bit. When you get a monomorphic spindle cell tumor, should I get fusion testing? Should I be looking for something? And am I sure that this is a fibroblastic tumor? Remember to look at the background. Does it have that collagenous appearance, right? Synovial sarcoma, for example, generally is not going to have a whole lot of like collagenous features, right? Now, treated synovial sarcoma completely different, right? And some subsets of them will have a bit more collagen, but a good sort of differentiator between SFT and synovial sarcoma is the presence of lots of like ropey collagen or kind of sclerosis in the background, right? So think about that. You have pleomorphic spindle cell tumors as well. There's a few in the fibroblastic category that fit into pleomorphic spindle cell tumors. So things like mixed fibrosarcoma. Low grade will have kind of scattered pleomorphism. High grade will have very diffuse pleomorphism, right? Myxoinflammatory fibroblastic sarcomas, superficial CD34 positive fibroblastic tumors. Symplastic changes may be seen, like, for example, we talked about myofibroblastomas and cellular angiofibromas that can have symplastic changes and get these sort of pleomorphic tumors. Right? And then outside of the fibroblastic tumors, there's a very sort of a common differential we think about when we think about pleomorphic spindle cell tumors. And this is something you want to approach every kind of pleomorphic spindle cell sarcoma in this way, right? Obviously, you want to consider PHAT. It's very rare, and it's just important to keep in the back of your mind, but you're pretty much not really going to make this diagnosis very often. But that has pretty diffuse pleomorphism throughout, but no mitotic figures, right? Generally, and we'll talk about PHAT when we get to it eventually. But more commonly, you're going to be thinking about, well, I should probably put carcinomas and melanomas. Those are probably your first thing to think about. And then things like D. diff lipo, pleomorphic lyo, pleomorphic rhabdo, pleomorphic lipo, and then undifferentiated pleomorphic sarcoma, which is probably the most common of those, right? So rarely you can have MPNSTs that have like much more significant pleomorphism stuff, but those are less common, right? So consider that kind of spectrum, right? There may be some epithelioid tumors that kind of fall into the differential. The main one that really falls into epithelioid tumors would be like SEF, right? So don't forget that one as a possibility, but you're also considering a number of other epithelioid tumors aside from carcinomas. You're thinking about epithelioid sarcoma, you're thinking about EHE, you're thinking about epithelioid angio, you're thinking about myophtheliomas or OFMT as well. So fibroblastic tumors generally can just fit into so many different spectrums, right? I think I have one more, right? Yeah, I have fat-containing lesions as well, right? So obviously, you'll be thinking about adipocitic tumors, things like spindle cell lipomas, very commonly through these fat-containing lesions. Neurofibromas can sometimes have fat, but there's a number of fibroblastic tumors that'll also have it. So any of the RB1 loss tumors that we talked about, myofibroblastomas, cellular angiofibromas, they can all have fat. SFTs, there's a lipomatous variant. Elastofibromas will often have admixed fat. Lipofibromatosis, like we talked about, the fibrous hamartomas of infancy, calcifying aponeurotic fibromas, these things will often have admixed fat. So as you can see, like there's a lot of fingers everywhere in the fibroblastic tumors. So just kind of keep that in mind.
There is no winning.
No, there's not.
The fibroblast one.
It's the most difficult, right? That's why it's 3 lectures, to be honest. It's the most difficult category of lesions generally. So I think it was fair to kind of give as much to it as possible. And I think that might be it, right? Yeah. Yep, there we go. We're done. Done it. Three
Fibroblast.
hours down.
Fibroblastic 1, Ahmed 0.
Exactly. Now you've at least got the introduction, kind of what all these are. Go back, refer to these. Obviously, come by if you have questions or just, I don't know, email me or whatever. I'm happy to answer. My email's on screen, and I actually do answer it. So feel free. Cool. All right,
Thank you so
guys.
much.
Thank you so much.
Any final questions, thoughts? We all good? Sweet. Great job, guys. Great job.
Bye.
Thank you, Dr. Herbert.
Of course. All right. See you later.